Hi, everyone. I'm Lindsay Lyon, Managing Editor at U.S. News and World Report. Welcome to today's webinar, Improving Maternal and Fetal Health, Taking Action for Better Outcomes. Our session today is the latest installment in our Healthcare of Tomorrow series, a forum for hospital executives and healthcare leaders to share insights, best practices, and perspectives on the future of care delivery. I encourage you to visit usnews.com/healthcare of tomorrow for videos and recaps of previous programs, and to sign up for future updates about events. Before we get to our panel, just a few quick reminders. We are capturing video of today's session, and we will be making that available to watch on demand for those who register. Look for a follow-up message from our team. We're also live streaming this session on the US News Facebook page. For those of you watching live, if you have questions, we ask you please type them into the Q&A feature on your screen. Our team will review and give voice to some of those during the course of the session. First, we'll have a segment on advances in fetal medicine, followed by a panel on the maternal mortality crisis. We'll play a brief video featuring a patient who underwent fetal surgery, and then host a conversation with her physician, Dr. Michael Belfer, chair of the Department of Obstetrics and Gynecology at Baylor College of Medicine, as well as obstetrician and gynecologist in chief of Texas Children's Hospital. Christine Comizio, health editor at US News, will moderate. Thank you all for being with us.
My name is Julia Wallace. I am a mother of my 5-year-old Nell Wallace and my 1-month-old Lucas Wallace, and I live in Baton Rouge, Louisiana. So when my maternal fetal doctor walked in, his face immediately changed, and he wasted no time in saying, "Julia, I want to discuss with you what I'm seeing on this ultrasound." It is where there is a lesion in the baby's spine, the spinal cord and the nerves are exposed to the amniotic fluid. And whereas the amniotic fluid would normally protect and support the baby, it was actually damaging those exposed nerves. So the longer the baby was in my uterus and exposed to that amniotic fluid, the more nerve damage was being done. I knew nothing of what my child was going to be like outside of that. What type of quality of life would she have? And that was very unsettling, because in your mind, you just have this image of this severely debilitating condition, and your image of your typical child is shattered. When our maternal fetal doctor started discussing what we can do, sitting here in this room, now that we know that she has spina bifida, here are some options. He said, based on the level of her lesion, which was fairly low on her spine, he felt confident that I was a candidate for fetal surgery. I chose Texas Children's because it is a hospital where I had been a patient previously. I actually had open heart surgery there when I was 19 years old for a hole in between the two atria of my heart to repair that. So I already knew that, my gosh, they did this. Well, surely they could help my daughter. There's a lot of power in having options, and just having a surgical intervention on the horizon brought what little peace there could be at that moment. The team of doctors, when they brought up the fetoscopic approach, they were very transparent in that I was going to be the 8th mother who underwent this particular surgery. And it was very nerve-wracking to know that there are not that many that came before you, and there's not much data at that time. I had the surgery at 23 weeks and 5 days, and it's just incredible to me. It never escapes me that the Nell was so tiny. And one of the instruments that they insert when they do this procedure is a camera. So they were actually taking pictures of Nell during the procedure. So I was able to see her foot. And it's just fascinating to me and enthralling that we're able to go in there and help a fetus at this stage in your pregnancy and be successful. They let me hold her for just a split second, and just gazing into her face, everything comes together. She's no longer Nell with spina bifida. You don't look at her through a clinical lens. You see your child, and you just realize that all of what you put yourself through, all of the risks that you took, this is your reward. This is the good stuff. Nell is, for all intents and purposes, a typical 5-year-old girl. She is wildly articulate. She runs without assistance, walks without assistance. She does have orthotics for long days at school to help support her legs, but by no means does she need them to walk on her own. She is one of the funniest women I know. And she's, people tell me all the time, they look at her and they say, if you had never told me that she has spina bifida, I would have had absolutely no idea that she had this diagnosis. She's just a joy. And once people know more about her and her story, they're enthralled and they see this light. And she has just changed so many people's views of spina bifida and of what that means. I feel that her story has brought hope to so many moms. They see, when you're confronted with this diagnosis, you see all the things your child can't do. But when you're able to fast forward to where Nell is now, you want to go give Julia 5 years ago a hug and laugh at her and just say, you have no idea what's in store for you. You have no idea how she'll change your life.
Wow, such an incredible story. Welcome, Dr. Belfer, and thank you so much for being here today.
Thank you.
So Julia and Nell were your patients, and this is something you've pioneered, the 2-port fetoscopic surgery, what Julia underwent. Very briefly, can we take a step back and look at what this procedure was? Can you describe it and how it compares with the traditional approach here?
Yes, certainly. The traditional approach at that time to fetal surgery for spina bifida was to make about a 7 to 10 centimeter incision in the uterine muscle, and almost always in the upper segment of the uterus, which would mean that that patient would need a cesarean section for that delivery and every subsequent delivery. And so the technique was developed really to benefit the mother. The surgery that we do on the baby is very similar to every spina bifida repair. In our case, it's been slightly modified. We've added a patch, we put a muscle flap, and we close the skin. But in terms of the benefits, the reason for developing this surgery and for doing a fetoscopic methodology is to benefit the mother, to reduce the risk of rupture of the uterus, and to, in fact, allow her to have a normal vaginal delivery. And on top of that, we are actually delivering patients now at a mean gestational age of over 37 weeks, so at term. And that reduces the risk of prematurity and all of the complications of prematurity for the baby.
Wow, yeah, so it's really taking a holistic approach, looking at the health of both the mother and the baby. And now you've done more than 100 of these procedures, Julia being among the first few. I think she said the 8th of there. Can you help us understand, sort of in the simplest of terms, how you and your team practice this procedure to ensure it was really ready for prime time?
Yeah, I think this is very important to get out there, that this is not a surgery you read in a book and then decide to do. You need to develop the surgery, you need to understand the risks and benefits of it, and you need to practice it. And in our case, we went to Barcelona in Spain to a friend of ours who was doing some sheep surgery and developing a different technique. We learned how to use the animal model and develop the animal model. And then Bill Whitehead, my neurosurgeon partner, and I came back to the US and made a simulator. Not a very sophisticated simulator at the time. It was just a kickball and a doll and some chicken. And so we wrapped the chicken around the doll, put the doll inside the ball, and then practiced the technique for hundreds of hours, because this is very different to regular laparoscopic surgery. We only use 2 ports. In order to minimize the number of holes we have to make in the uterus, we only use 2 ports. So that means each one of us controls 1 instrument. And there's quite a dance and a chemistry that has to develop between 2 surgeons, one of whom controls exactly what the other one sees, and then do intricate movements, which include suturing and cutting tissue, when each of you only controls 1 instrument. So that took hundreds of hours of practice, and we developed the technique. And then we took that technique back to Barcelona and practiced it in the animal model. And then we were ready in 2014 to do our first human case.
Wow, it's an incredibly innovative approach to get where you are now. And just recently when we spoke, you were jetting off to Germany later that same day to train some physicians overseas in this procedure. So talk me through this a little bit. What's the significance there of your work in this space, and why is it taking you all over the globe?
Well, initially there was a lot of resistance to our technique because we use carbon dioxide inside the uterus, and people just didn't buy it initially. But now there's a lot of excitement, and people understand, as we presented the data, that this really is the future for fetal surgery, that there's no need to expose the mother to these long-term, really serious risks. And so there's been a lot of excitement, and we held a simulation course about 2 years ago, just before COVID, in fact, and we had 18 teams from around the world that came to learn in our simulator. We've got a little bit more sophisticated in the simulator, and then they went back to their countries. And recently I've started going to these places as they begin to do their first cases. And I think that's a responsible way to do this, to go and to be with them and to actually help them with their first cases. And it's amazing that we're doing this, because I just received a text today from the patient in Germany that I helped. And she said, "Dear Professor Belfer, we were very pleased to meet you. We are now back home and our baby is doing great. She is doing her daily training and increasingly focusing on intensive leg work. We are especially happy about that. My husband and I still have many conversations about the surgery. We cannot imagine a better method for prenatal therapy. We are more than grateful to you and your colleagues in Marburg from the consortium, and we are looking positively into the future and very much looking forward to finally meeting Hannah when she's born." And that's just, you know, I get these kind of texts quite frequently, and it's so heartwarming.
Absolutely. And, you know, speaking of watching that video with Julia and Nell and seeing where Nell is 5 years later, I mean, that's pretty phenomenal. Can you talk me through, I mean, that must have been daunting, both as on the side of the physician for you and for Julia as the patient, and making that decision, just being, you know, the 8th person to have this. Can you talk me a little bit through her decision and going through that, and how you worked with her together to make that decision for her care at the time?
Oh, absolutely. Well, you see, from the the video, Julia is an incredibly articulate and intelligent woman, and she got it immediately. She asked great questions. We were very forthright. We made sure that she understood that this was experimental surgery, that there'd only been a few patients ever that had this kind of surgery. We discussed the benefits, but we focused mainly on the risks. And I think that it's crucially important whenever you're doing something innovative that the patient have a full picture of the risks involved. And we gave Julia, right up until the moment she went to sleep, the opportunity, and she'll remember me saying, "Are you sure you still want to do this?" on the morning of the surgery. So one has to be very careful when you're developing these innovative things that you don't bring your own enthusiasm for the procedure or your hope for the procedure into a reality for the patient. And so that is a crucial part of the team discussion. And we actually have an ethicist as part of our team.
Wow. Yeah, it takes an immense amount of bravery for the patient. And I'm sure it was daunting for her, but seeing her now 5 years later is really encouraging. So this is, this procedure really is the first step of many. And looking at the bigger picture, where are we headed in terms of advancements to improve the health of both mothers and babies? Where do we go from here?
Well, I think we've brought a new surgical space into being. You know, the uterus was not generally thought of as a place to do surgery. But with this study and with our results and the fact that we can do quite intricate procedures inside the uterus, there is now hope that other procedures can be performed in a similar environment. And in fact, we are developing one right now that we hope within the next year to do the first human cases, and that is to repair an abdominal wall defect, so-called gastroschisis. And we think that this will be of great benefit. So I think the future of fetal surgery is bright. And I think that we have now this new surgical space in which to innovate and to try and do things for these children.
Great. And I have one final question for you here. And just on some takeaways, implementing this new procedure and program has really been a big step for you and for your team at Texas Children's. What might you caution other healthcare leaders with this sort of technological undertaking or generally starting up a new program of this size?
It's a great question, and it does bear warning. The fetal center that wishes to take on this kind of surgery needs to be one that has adequate resources. There's no penny pinching about this. And I think the administrators and the hospital medical leadership need to understand what they're taking on. I think that you need a large multidisciplinary team. This is not simply the surgery. There's a huge amount of work that goes into screening these patients, in ensuring that they're qualified candidates, in counseling them, in providing social and psychological support, in bringing in all of the necessary consultants. We have at the Texas Children's Fetal Center, some of the world's leading imaging experts, some of the world's leading neurologists, pediatric cardiologists, urologists, orthopedic surgeons. So all of this needs to be brought together in a multifunctional and multidisciplinary team. And then after the surgery, you need to have a NICU in case the baby is delivered early. And then you need a spina bifida clinic that will follow these children for at least 5 years, because there's potential neurosurgery and other procedures needed. So this is a huge undertaking. This is not something that any hospital can decide, oh, we want a fetal center and we'll start doing this kind of surgery.
Great, that's fantastic. Well, Dr. Belfer, thank you so much for being here today. It was a pleasure speaking with you.
It's my privilege. Thank you.
Thank you both for those fascinating insights. Now I'm pleased to introduce our panel. Over the course of the discussion, they will examine the maternal mortality crisis and the action being taken to curb deep disparities. First, we have Dr. Christina Davidson, Vice Chair of Quality, Patient Safety, and Equity for the Department of Obstetrics and Gynecology at Baylor College of Medicine and Texas Children's Hospital. Dr. Eugene DeClercq, Professor of Community Health Sciences at Boston University School of Public Health and Professor on the Faculty of Obstetrics and Gynecology at Boston University School of Medicine. We have Jenny Joseph, midwife and executive director of Common Sense Childbirth, Inc., and founder of the National Perinatal Task Force. And Dr. Elliot Mean, director of the California Maternal Quality Care Collaborative, chair of the California Maternal Mortality Review Committee, and professor of obstetrics and gynecology at Stanford University. I'll turn it over now to Chelsea Ceruzzo, U.S. News' public health reporter, who will lead the conversation. Chelsea?
Great. Thank you all so much for being here today. I really appreciate it. Like Lindsay said, my name is Chelsea Ceruzzo, and I'm a public health reporter here at U.S. News. I kind of wanted to start out by taking a look at the scale of the problem in the US. The US is believed to be one of the only developed countries in the world where maternal mortality has actually increased in recent years. A CDC report found that maternal mortality surged just before the pandemic, and numerous reports have shown stark disparities in maternal death rates and maternal morbidity rates, particularly with Black women facing the highest risks. I'm wondering if we can just start there. I mean, where what is the problem from where you all sit? And Gina, I would love to start with you. I know you've worked on some of these reports detailing the problem. Can you give us some insights into what we're facing? Oh, and I think you're on mute, Dr. Clerk.
I just wanted to get everybody used to the idea that this is a Zoom meeting of one type or another. Sure, there's familiar aspects, and I think you've touched on those. There's the problem of documenting these trends, which has been a major issue in the United States. You're right, we're worst among developed countries on this. There are substantial racial disparities. I think those are the familiar things, but there's some elements of this that people are less familiar with that I just wanted to note. One was that only 1/3 of the maternal deaths actually occur at the time of birth, either on the day of birth or within the 6 days after birth. About 1/3 happen during pregnancy, and about 1/3 occur between 7 days and a year after birth. And I think once you start thinking about it in those terms, it changes the nature of the discussion. Also, while we fare worse than other countries and we have massive racial disparities, if you limit the comparison in the United States to white mothers and take their maternal mortality rate and compare that to other countries, we're still last. And I think that's important to keep in mind as well, because it's not to underestimate the importance of racial disparities at all, but it's to note there are deeper systemic issues that we need to address in the United States as well. Also, if you look at there's different measures of maternal mortality, you'd think this would be simpler, but it's not. But overall, national rates of pregnancy-related mortality have actually been flat for about a decade, since about 2010. When people talk about the rise, they're generally talking about the rise that dates back into the early 90s. But for the last 10 years, it's been about level. And if you break that down, one of the things you see is that maternal mortality in hospitals, again, roughly at the time of birth, has actually been going down through this period. That plateauing is a function of those rates going down and deaths in the community going up. And then finally, I'll just note that if one looks at overall death rates of women of reproductive age, not maternal deaths, but overall death rates, they've actually risen more quickly than pregnancy-related mortality rates have in recent years. So all of this comes together to suggest something, a theme I'm going to bring up through this, which is part of this is a medical problem, but part of it's a public health problem that needs to be dealt with at a community level as well.
Thank you so much. I appreciate it. Christina, I'd love to turn to you now. I know you work within hospitals, and I'd love for you to talk a little bit more about your work and how your team has been addressing maternal mortality and morbidity.
Sure. So as you mentioned, I oversee quality, safety, and equity at my hospital. And live in Houston, Texas. I'm at Baylor College of Medicine. And so one of the things, there's been a few changes over the past couple years in Texas of things that all hospitals or most hospitals are working on. One is Texas Levels of Maternal Care, which is a system set up by the state by which hospitals, it's really designed to make sure women are receiving the care at the hospital that's best equipped to meet their needs. And all hospitals have to satisfy, some of the same requirements. But in terms of hospitals that may take care of more complicated patients, it's important for them to be able to prove that they can take care of those patients, or that they have processes in place to transfer them elsewhere. So as that was being developed in Texas, we also started doing something called Texas AIM, which is the Alliance for Innovation on Maternal Health. And that's where hospitals, it's more voluntary, but almost all of the Texas hospitals have volunteered to do it. That's where we work with the state to participate in implementing patient safety bundles in our hospitals. And I know Dr. Main can speak a lot more to that, but from a unique hospital perspective, and then the Joint Commission has even come out with hospital requirements that are really basically implementation of the OB hemorrhage and hypertension bundles, which is also part of the framework for the Texas Levels of Maternal Care, with all of these things being designed to reduce morbidity and mortality of the more common causes, which center around hypertension, hemorrhage, infection, venous thromboembolism. So we've talked a lot about mortality on an individual hospital level. Fortunately, hopefully, you're not going to have a huge problem with mortality, or actually a lot of patient deaths. So one of the things we really have looked to focus on at my hospital is looking at the morbidity. And severe maternal morbidity as a general concept is defined as the long or short-term consequences that can be related to a woman's health around the process of labor and delivery. So she comes into the hospital to deliver, and then she ends up having a complication as a result of the delivery. And the most common cause for that is needing to be transfused after a hemorrhage. And what we also see in the data is that for every maternal death, there are at least 100 cases of maternal morbidity. And so death is looked at as like the tip of the iceberg, with all of these other morbidities leading up to that death. And where can we intervene along the way to reduce the morbidity so that we don't get to the point of mortality? Those deaths in the hospital are likely due to a lack of recognition and responding and acting on a deteriorating condition. So that's been a lot of focus of the work that we've done. And in doing so, we have started looking at our outcomes stratified by race, ethnicity, and primary language to identify where those disparities may exist, and try to work at identifying root causes and implementing equitable action plans so that we target what each individual may need.
Great. Thank you so much. And I appreciate you expanding on the definition of morbidity and what it means to look at it. Elliot, I'd now love to turn to you. So you chair the Maternal Mortality Review Committee in California, as well as oversee the California Maternal Care Quality Collective. Can you tell us a little bit more about those bodies and what they do?
Thank you, Chelsea. I'll be happy to. But let me first say that one of the root causes is that the U.S. actually excels at high-tech medicine. But spend very little time looking at routine basic care. We can extol our intensive care units, whether it's for NICUs or for adults. We can now do prenatal diagnosis with a minimal amount of blood from the mother. We can do fetal surgery, but we don't spend a lot of time on routine prenatal care or support of women in labor or postpartum. They're at the bottom of the list and get very little attention and actually very little reimbursement for. And that's something that's a fundamental issue in the American healthcare system that we really need to address. So I chair the Maternal Mortality Review Committee for the state of California. And California has 1 out of every 8 births in the United States. So we're a big state with a lot of births. And so now we have, because we have over almost 500,000 births a year, there are a lot of maternal deaths, a lot of maternal tragedies, which allow us to put together stories and to really examine not only the epidemiology or the numbers, but what are the quality improvement opportunities that we can glean from these cases, because we have enough cases to really put them together. So that's one of the hats I wear. Another hat is as chair of the California Maternal Quality Care Collaborative, which is charged with doing action steps. It's taking the lessons learned from maternal mortality reviews, from examining severe maternal morbidity that Dr. Davidson was talking about, and putting those into toolkits, but more importantly, actually leading collaborative efforts among multiple hospitals at the same time. We have 230 hospitals in California, and we try to run collaboratives with at least 100 hospitals at a time to really change practice, change culture on a unit. Now, what the struggle is that maternal deaths are actually quite rare, which is a good thing, 1 to 2 per 10,000 births. But they're each individually a catastrophic event. I mean, it's a tragedy for the family, for the mother, etc. So, but we have to be able to take the lessons and impress those, and then to do the improvements at scale, so we can see changes in morbidity as well as changes in mortality. So it's really wrapping up the lessons learned from mortality reviews and turning them into meaningful lessons that then can be implemented at scale. We'll have more chance to talk about this later.
Yeah, great. Thank you so much. And Jenny, now I'd love to turn to you. You're a midwife and you run Common Sense Childbirth. I'd love to hear more about your work.
Yes, thank you. Yes, indeed, I'm a midwife. I've been a midwife now for literally 40 years, some of it in the United Kingdom where I trained, and the last 30 years I've been in the United States, in Florida. I think midwifery has many answers to many of these ills. Certainly the model of care is a patient-centered, person-centered, woman-centered, family-centered model, where somehow that type of relationship with patient to provider is protective. We know that, we don't use midwifery as our main maternity care practice here in the United States. I believe, and many others do agree with me, that that would be a great help towards these ills. And in my work, what I've been able to do, though, is to utilize midwifery model of care to reach a larger scale and to reach community members who may not be even interested or choosing midwifery, but rather the support that they get in the prenatal and postpartum makes the difference. So at Common Sense, what we've done is we've provided a wraparound using a midwifery basis to provide care to the majority of pregnant people who choose hospital birth. So as Dr. de Klerk mentioned, that community-based work is protective, and it also is where much of the morbidity and mortality is showing up. So I strongly believe our work has illustrated that there's a way to provide safe, quality care to impact the outcome before, in a preventative stance, rather than a sort of after it's happened or in the middle of. We are not seeing these outcomes in our populations, and these are women who are generally more likely to have poor outcomes, such as low birth weight, prematurity, preeclampsia, have less support postpartum, and have postpartum medical as well as behavioral issues, and also not breastfeed. So we see the complete opposite just by applying a model of care, which is very cost effective, which is easy to train, which is easy to scale. And we found that that has been the main work that has transformed outcomes, and it's very much so protective to women who are marginalized across the board. But every woman that has been through our program has found a way to, I guess, sort of survive literally what's currently so in the United States, and the most egregious statistics that I think we have to address them now. There is no excuse. It's time for change.
Thank you so much, Jenny. I appreciate it. I want to focus a lot of this conversation on solutions, and I know hospitals are one part of the equation. According to the CDC, 1/3 of maternal deaths occur during delivery or in the week after. So Elliot, I actually want to come back to you. We've been talking a little bit about these safety bundles, and I know part of your work is bringing them into hospital settings. What are these bundles, and how do they address maternal mortality and morbidity?
The two most common preventable causes of maternal mortality are hemorrhage and hypertension, as Dr. Davidson mentioned earlier, and they are preventable by the use of standardized approaches to care. It standardized approaches to diagnosis, standardized approaches to first and second steps. No one doubts for a moment that if you analyze a cardiac arrest, that you should have a standardized approach for a code team. That is the same thing that we need to have in every hospital for a major hemorrhage or for a hypertensive emergency. And those are now being adopted, and they've been endorsed by national bodies like the American College of OBGYN and now by the Joint Commission as a standard for hospital care. These bundles have elements that are addressing the acute events, but they also have some elements that address prevention and early recognition so they can be headed off. But as was pointed out, maternal deaths happen outside the hospital as well, and that's a big challenge here. And in fact, the big rise in maternal deaths, as Dr. de Klerk mentioned, has been in what we used to call indirect causes. Direct causes are hemorrhage, hypertension, infection. Infection is actually going up a bit in most recent numbers. But the big rise is in cardiovascular disease and underlying medical conditions. And those are the ones that dominate after you leave the hospital up to a year of birth. And those also include substance use disorders leading to overdose and mental health conditions leading to suicide, which are pretty rare during pregnancy and immediate postpartum, but rise as you get up to the year post-delivery.
Thank you. I appreciate it. And Christina, for you as well, I know you also use bundles in your practice. What do they look like for you, and how are they addressing maternal death rates and morbidity rates in your practice?
The bundles, if you ever see one, they're often just 1 or 2 pages. So while it may be addressing hemorrhage or hypertension, it's not a lengthy document that gives you all of the medications to use, or it's really it's divided into 4 different domains that we often refer to as the 4 R's. It's readiness, recognition, response, and reporting and systems learning. So each domain has a list of elements that your hospital should have in order to be, ready to take care of this patient with this condition, respond to it, recognize that it's happening, respond to it, and then learn from it, review the cases. And so I think what's very interesting about them is that hospitals may implement them slightly differently. I work in a hospital that is, has a massive blood banking capability. I, have no problems getting all of the blood components that I need, but a smaller hospital may have to be more creative in how they're going to do that, but it gives them the ability to talk with their hospital about needing that and having to be able to develop that resource if they don't already have it. So at my hospital, it really just, involves what we generally start out doing is we look at all of the elements of the bundle. We did this with hemorrhage, and we're going through it now with hypertension. And we look to see, what do we already have in place of these elements? Do we already have it in place? If so, is it working well, or do we need to further develop it? And if it's not, if we don't already have it at all, then we need a team to work on it to develop it. And then we really create teams for each of the bundle elements to work on it. And then there's, and it involves everyone. It's not, I'm by training maternal fetal medicine. I still practice clinical medicine regularly. And so, I am able to see when we implement something, is it working? And that's the whole reporting and systems learning, is that you then need to go back and identify, what could you be improving upon? One of the things, for example, with hemorrhage is, while we saw a reduction in our transfusions, one of the things that we want to focus on now is, how can you avoid the need for transfusion altogether? And maybe you can't avoid the hemorrhage, but if she gets admitted at delivery with anemia because we didn't correct it during all of those opportunities in prenatal care, then she's more likely to need to be transfused even with a normal blood loss. And one of the ways to put a health equity focus on that is, some of the other things about the data, and I was embarrassed to recognize this, or that I hadn't recognized it, is, as a Black maternal fetal medicine specialist, I felt like I should have known all along that these disparities existed, not because of comorbid conditions or socioeconomic status or income, but because a lot of it is due to implicit bias and racism and social determinants of health and structural factors that really have led into, before she even presents for her first prenatal visit. And some of the definitions that have existed in the literature using race-based definitions really are not based on any biological factors. And there's even been, quoted in my specialty, different cutoffs for anemia for a Black woman versus, other races and ethnicities. And so we have gotten rid of that. Your target hemoglobin is X, regardless of your race or ethnicity, because then if you say that a Black woman's normal hemoglobin is lower than a white woman's, and then she comes in and experiences a hemorrhage, she's more likely to need to be transfused because her hemoglobin is going to go down lower. So it's those types of things when you really try to look at root causes and, where can we make the impact? And a lot of this is outside of the hospital. So we implement our bundles, but we also look for opportunities of improvement outside of the hospital. But I think an opportunity for improvement with us is more partnering with the community, because one thing is the prenatal care. We can impact the prenatal care, but we're trying to better understand how we can impact what really happens once they go home after delivery.
Great. Thank you. And I'm so glad you both talked about out of hospital interventions and partnerships with the community. I'm hoping to get to that soon, and I'm just so excited about that as well. But before we move off of the bundles, one thing I did want to ask both of you, and Dr. Davidson, I'm so glad you talked about improving bundles. What other ways can we improve bundles? And with that, how can we get bundles in more hospitals in the United States?
Sure. Well, first of all, bundles by themselves don't do anything. You have to implement them. And implementation ends up being the biggest challenge of all. Getting people to change their behaviors, their practices, their attitudes is the hardest part of quality improvement in medicine. And so you have to do things like be transparent, public reporting, having Joint Commission involved, getting the CEOs of hospitals to recognize that this is an important area to put resources in for training and for having nurses that are leaders for quality improvement. You need people on the floor to be leaders in changing care, but changing culture, because a lot of this is about culture and attitudes. And it's where there's always a lot of subjectivity in how we do things, or in many of the areas in medicine. And where there's subjectivity, that's the entree or the entrance point for bias, in explicit or implicit bias. And so the more that you can get rid of some of that subjectivity and have a standardized approach to care, that removes the opportunity for the bias to enter. So by having a statewide collaborative, we've been able to engage just about every hospital in our state. So we approach that by networking, and that includes working with all our hospital systems and getting them engaged to do these, working with our university referral networks, working with our regional perinatal programs. And so it's a lot about personal touch, as is if you're going to create change anywhere in the healthcare system. You can't just say thou shalt do this. You have to really sit down and explain why it is, and then follow up and show them their data and show them patient feedback. We're doing a lot now with patient-reported experience feedback, which is really important as you get into the areas of disparity and inequities in medicine. You got to listen to patients at the same time you're doing these. Christina.
No, I have nothing to add to that. So I think you covered it all so nicely. I agree.
Great. Thank you both. And as you both have been talking about, I'd love to talk about partnering with community organizations and community-based care. And like you both have said, it's important to look at what happens after someone leaves the hospital. According to the CDC, 1/3 of maternal deaths occur 1 week to 1 year after delivery, which I know is why Jenny and Eugene would say community-based care is so crucial. Jenny, I'd love to start with you. You founded the National Perinatal Task Force. Can you tell me what that is and what you do?
Yeah, so that really grew out of our work, recognizing that one, midwifery model is one way of getting things done, certainly a very effective way, but there's so few of us. You know, we are growing our profession as best we can, as quickly as we can, but in the meantime, we need to scale. And so what really came to us was the recognition that there are so many community-based, what we call embedded providers who already are providing midwifery model care without being midwives. I'm talking about the doulas. I'm talking about childbirth educators, lactation supporters, community health workers, birth workers, perinatal support folk who are a workforce that is somewhat unrecognized in the value of what they could bring to this particular issue. Where women and families feel that support, that personalized care, that respect, where their dignity is maintained, they thrive. And so we've created the National Perinatal Task Force to create this network of support on two fronts. One, obviously, to reduce and eliminate disparities, and for that, for the general public, for the community itself. But two, to recognize, support, uplift, train, and to deploy these we're overlooking these birth workers, these perinatal folk who are outside of the main system, but could actually come alongside the system and be very effective. So we call these little hubs of care perinatal safe spots. And our goal is to blanket this country literally with almost a perinatal safe spot in every corner. Where we have already established these safe spots, people know where they are, the community knows where to go. This is where you can really be protected from what I call maternotoxicity. And really that's my sort of made up description of where you might be, where you as a mama, baby, dyad or family are not safe being pregnant, parenting, postpartum. And it could be because you live in maybe one of those, areas, zip codes that are not, healthy zip codes, food deserts, etc., violence, stress, and so on. Or it could also be the toxicity that pops up around you because of your race, because of your ethnicity, because of what marginalizes you. We have to be really clear that, just as been said already, this is about bias sometimes, this is about pure racism sometimes, this is about classism for sure, sexism, this is about power, right? And at the end of the day, where people do not have true access to quality and safety, they suffer. So, and in our work in the National Perinatal Task Force, we are addressing one family at a time, one community at a time, how we can take the resources that are already there. What we need and what we're asking is that people join us in investing in our community providers and partnering with our community partners. We want to collaborate. No one wants to be a silo. No one wants to be out on the edge doing the lone wolf independent thing. It's time for us to come together because we have solutions which are absolutely available to us right now. So the National Perinatal Task Force is basically, we are operationalizing perinatal equity. One of our taglines is that we believe we are building a movement to birth a more just and loving world. It's going to need to be that approach to meet this horrendous problem that we face in the United States today.
Thank you. And Jenny, I know from our conversations we've had and my own reporting that midwives as well as doulas can give a lot of respect and power to birthing people. How do you better integrate them into the community, and what barriers are there to increasing the numbers of midwives and doulas as well?
Oh, those barriers are rife. A lot of it is about attitude. A lot of it is about understanding. There's so much drama and fear and concern around what is this? Is it safe? Is it okay? Is it acceptable? It's been really difficult for me. I've been in this country 31 years and I'm still reeling from the fact that midwifery is not normal. It is not the standard way to provide maternity care. If you think about it, generally, the whole maternity year, the childbearing year, there's nothing wrong with you. It's not really pathological until it is, right? And so we know that people have attitudes and concerns. A lot of it's because of the lack of knowledge. So to clarify, a midwife provides health care and support to normal pregnant women who are having healthy pregnancies and straightforward cases. a doula provides non-medical support to families and people who need that emotional and physical support, advocacy, and, you know, really championing to get them to feel well taken care of and to be understood, to be listened to. Those types of skills and arts, those competencies are not the same as maternal fetal medicine or, you know, high level perinatal care, but they are way more effective in preventative. And so we need to scale. We have opened a school of midwifery training where for the first time we are now able to bring in diverse students, which we weren't able to do before, because we realized that this is where we need to grow community-based workforce that can provide these services. But there's no shortage of people interested in these career paths. And again, it comes down to recognizing that if we work as an interdisciplinary perinatal team, all layers and levels of that team need to be supported, need to be invested in, and we have to prepare for our future by growing that workforce. This is where I think we can make a tremendous difference and not have to keep wringing our hands and wondering, what are we going to do about this mess? It's time for that change.
Thank you, Jenny. And coming to you, Jean, I know you've also written and talked about integrating care into the community, as well as ensuring care for new parents continues after they give birth. How else can we do that? And what obstacles are there to doing this effectively?
You know, you've put together a pretty good panel. They've taken most of my good stuff already. But given that, let me just note a few things. The biggest one is inertia, right? We've got a system that's not focused just on women's health. The entire health system in the United States is focused on treatment rather than prevention. And that manifests itself here as well. And so we'll invest a huge amount of money on treating a particular problem. And we're so much more reluctant to put the money into programs like Jenny's that focus on prevention. And so that's an element of it. Another element of it is the focus on women's role as mothers and birthers, as opposed to women's health per se. Part of what Dr. Davidson, I think, appropriately noted was there's too many women who come into their pregnancy already in poor health. And you can't set a system up that says we're only going to care for you for this 21-month period of pregnancy and out to a year afterwards, and then we're not going to worry about it, because that's when you've served your purpose. Jenny touched on the diversification of the workforce, which I think is really critical and is at least more potentially possible among midwives, because the training period is shorter. And so if you ask me for one solution, I would focus on that. If you compare the United States to other countries, we're close to even with other countries in terms of obstetricians per birth. We have 1/9 as many midwives per birth as do other industrialized countries, all of whom have better outcomes. And so that could be a focus. But again, it runs into the cultural barriers that Jenny was talking about. There's policy problems, which I think we're going to get to a little bit later. And I'll note one last one, which is documentation. When you're dealing with things like JACO and major organizations, and they're trying to think about how are we going to document good care, a lot of the kinds of things we're talking about are very difficult to document. You know, it's one thing to say we're going to look at infection rates, or we're going to look at rehospitalization rates, because we can document that reasonably well. It's far more difficult to come up with reliable measures. They are out there, but they're hard to apply on things like racism or respectful care. And those things involve actually listening to the patients involved. And our systems have not, to this point, done a lot around it. They're doing much more now than they've done in the past, but it doesn't fit the standard model of let's look at ICD-9 codes for billing to make our decisions as to what's an effective treatment and what's not.
Thank you. I honestly would love to open up the floor to anyone here, since we have such a great mix of people with different experiences. What opportunities are there to partner for community-based organizations to partner with hospitals and as well as midwives and doulas? I mean, what does that look like? What does success in that look like?
Can I jump in here? I do think that what we found already is a great model. You know, we see where we have support. So I'm going to talk a little bit about what we call the Easy Access Clinic. So that's an alongside clinic. It's part of the community access point for outpatient maternity care. But because we've been able to work very closely with our regional hospitals and create relationships, particularly with the hospitalists and the doctors who are on staff to deliver mothers in the hospital environment, we've been able to measure, much better outcomes through being able to do prenatal care and postpartum care, but have the hospital support for the delivery, which is the choice of the majority of American mothers. They still choose hospital, even if they want midwifery, they want to have a hospital delivery. And so we found that the key to an easy access clinic model is that there's an agreement that we all just work together, whether or not, the midwives actually deliver those babies or not, but rather that the mother and the family get to choose. This is about options. And I think that was so well pointed out by Dr. Belfer in the earlier segment. Where people have options, they will be safer. And so we've provided an option in our communities where we have easy access clinics, that is a smooth transition along with an interdisciplinary approach, a collaboration that very quickly solves all of our problems collectively. And so we know that with investment from hospital systems and organizations into community-based practices like this that are coming alongside, we are actually getting much more traction and also being able to scale. The key here is we have to keep replicating what's working. When you can get a prematurity rate of 1 baby out of 482 women that went through that clinic last year, the Easy Access Clinic patients, 1 premature baby in the COVID year, no less. That's well worth looking at, being a model that could be replicated, that could be supported, that becomes part of an overall system, an ecosystem where perinatal equity is embedded because the model of care itself creates the equity.
I think one of the biggest challenges we have is breaking down silos, because you have a medical care system that has done things in a certain way for a number of generations, and there's inertia, as Jean was saying, about change. And then you have public health programs, lactation support, or a variety of outpatient public health programs that are not that often eager to work with hospitals. And so it's in many of our states, many of our places, it's been an issue of lack of trust, lack of familiarity with each other. And the future is that you have to break down those silos, and you have to do it a step at a time. It's not, you can't come in and say, okay, now we're all going to work together. You have to be able to show numbers like Jeannie's numbers, and you have to be able to show that it can happen locally. To make change, you have to bring it to your own state or so forth. Because people will say, well, that can happen in California or New York or Florida, but we're different. And the reality is we're not that different. But that's human nature. And so you have to have some leadership of folks at hospital administrator leadership, physician leadership, and community leadership to get together and say that we need to invest and agree to work in a different way. And then it can build. We're working on that with several of our hospital centers in California. And we think that's encouraging, but it's a slog to change care. What have you done in Texas, Christina?
The only thing I was going to add is one other opportunity I think that we've really started to focus on at my hospitals is around screening for social determinants of health and helping the patient work through some of those. So we've really tried to change the narrative. I feel like as physicians, we, may have been quick to label a patient non-compliant in the past without really understanding, what are the barriers to the compliance. I have learned so much from my patients in this, and I think it's, now it's being taught. Actually, after this, I'm going to go over to the medical school because the incoming first-year medical student class now has an orientation on social determinants of health, and they just ask for faculty to facilitate it, but the entire syllabus syllabus is written by medical students. And, you know, being in Houston, and if it's not the most, one of the most diverse cities in the country, we, you know, see patients of all races and ethnicities, all nationalities, all different languages. I sometimes am in clinic with a different interpreter in every single room I go into. And what I have learned is, you know, if they didn't bring in their blood sugar log, or if they didn't check their blood pressures at home, or if they're not taking their medicine correctly, then we ask the questions, you know, is there a particular reason you're not able to do this? And sometimes it's as simple as, this isn't a good day of the week for me to come to clinic. My husband has to, you know, work, and, you know, Wednesdays is his day off, and then he can bring me in. Can you change my appointments? And other things that may be, you know, the medical center is not a fun place to park or to get to. It's expensive and it's difficult to access. And so, you know, barriers to transportation, and, you know, are there vouchers that we can provide? But if we just look at, you know, somebody and label them as non-compliant, then, you know, and they're not in that circumstance because they're not a hardworking person. That's where the structural racism and barriers have come into play. So as much as we can, how can we connect our patients with the resources that they need to get the best care? And that may be through our social workers, through food banks, through transportation, you know, whether it's childcare options. So those are things that I think can be, it may seem overwhelming, but just asking a few more questions sometimes can really lead you to some simple solutions in the middle of a busy clinic.
So I think it's super important to be able to screen for social determinants, but it's also really important that the providers, physicians, midwives, and nurses know what the social services that are available, because oftentimes we don't. And that's a really, it's a key missing piece that we need to do a better job on.
There's a couple other players that we haven't mentioned. One would be funders. You know, I teach in a school of public health, and my students inevitably come up with a solution to the problem is we're going to have obstetricians or doctors in general do more stuff with their patients, and we'll do a training for them, and then they'll change their behavior and everything will change from that. And I point out to them, but this doctor has to see X number of patients an hour, and unless someone changes the system to allow them to do those things that you're talking about, there won't be change. If someone has a nut to meet of seeing so many patients in a given time period, simply telling them, and you also have to screen for this, and you also have to do that, is not going to work. The other player I think that we haven't mentioned would be community health centers, which are often not associated with maternity care as much as they might be. Although they end up doing a fair amount of it. Likewise, community health works. We talked about doulas, but when people talk about doulas now in the policy world, they're really talking not so much about doulas as labor support people. They're talking about doulas as community support people. And that's fine. And I'm glad they're doing that. But the fact of the matter is we've got decades of community health workers who have been doing these kinds of things, but we haven't really focused much on the maternity care side of it. And they can play a critical role in linking up people to the services they need, and maybe take some of the burden off of the clinicians to have to provide all of that patient navigation work.
I do second that, Dr. DeClercq. The community health worker is the new old midwife of, you know, the grand midwife, the community-based midwife. We have been training community health workers in maternal child health specialties. And we found that, you know, many of them already are doulas or lactation, but adding that extra piece for them has empowered them to be really much more able to be resourceful inside the community, but also to collaborate back with the providers. And so they're almost like extenders, if you will, but they are readily accepted, they are trusted, and they are easily trained as well. It's really a very quick and cost-effective training. But we know that these are the best folk to actually man the perinatal safe spots. We found that the community health worker leaders are the best places to site the safe spots in the community, but also virtually. Since COVID, of course, we pivoted to telehealth, but that was when we discovered the power of telehealth, and particularly using the community health worker model. And so if you think about the dearth of providers we have in these rural maternity deserts, with the telehealth skills that we train our community health workers to use, they are now able to reach out rurally from hubs where they couldn't before. And again, moving everybody through a system where they end up with the support, whether it's from perinatology on down, or whether it's from community health worker up. It's a continuum of care, and the gaps are being filled, and we're not having people falling through cracks like they used to, simply because this model, we can scale. There are more players available and readily trained, and it begins that pipeline as well to medical careers. So I love the community health worker model, and I think that is a model of the future that we can really use to address this crisis and to build this movement.
Thank you. I'd love to kind of transition into something we've been mentioning throughout policy. As you all know, I'm a huge policy person, so I'm so excited to talk about this. We've seen a lot of momentum, including on Capitol Hill, to address maternal mortality with a particular focus on healthcare disparities. And you guys have all touched upon this. You know, there are these very, very big disparities that we're seeing in maternal care. Black women are 2 to 3 more times more likely to die in childbirth than white women. Last year, lawmakers unveiled a sweeping maternal health package called the Momnibus, which has been reintroduced this year with likely backing from the White House. And it aims to tackle maternal mortality through implicit bias training, funding for community intervention, and data-based tactics. One bill in particular is named for Kira Johnson, a Black woman who died shortly after giving birth due to hemorrhage bleeding, and her husband has visited Capitol Hill numerous times to talk about what happened and medical bias. My question for you all is, I know we've spoken about being familiar with this package. You know, is this enough, and what's in it that's really important to you? And feel free to jump in, anyone.
Yes and no. Yes, but my policy side says it's not all going to pass, because that's not how things happen nowadays. And so the question is going to be what can get, not what could ideally be happening, but what can get through. And there are components of it that have more potential. You know, the easing of the process of extending Medicaid out to a year postpartum is got some potential, but that's a costly one. And so there's going to be pushback based on that. There's elements of the Momnibus that involve perinatal workforce issues, which is great. It's Jenny will love this. It's about training midwives, but the funding for it is pretty small relative to what the need is. And so the question is, do you accept something that's less than ideal to get it moving? And my answer usually is yes. That's the way the policy world works, that if you wait for the ideal, nothing ever happens. So you have to take the piece of the pie that you can get while you can get it. There's elements of that about improving data collection and measurement, and that's fine. I'm a data person, but at the same time, the real solution is not going to come from measurement. It's going to come from actually getting in the field and providing services for people. And there's some elements of all of that. The Charles Johnson's bill, the Kira Johnson bill, involves training around bias, and that's valuable. So yes, it would be nice. The real question will be what's going to get through in all of this. You know, which of those pieces are actually going to happen, and how can we structure this as a bipartisan effort? And that's the biggest challenge, is getting it through the US Senate, to be honest.
I'm slightly encouraged because for the first time, like you say, 31 years in the United States, and for the first time, I saw some real solid, focused approaches to what we need to do about this particular issue. The fact that these set of bills, there are 12 in the Momnibus, addressed Black maternal health and Indigenous, it really focused on the fact that this is a particular problem for people of color. What is important here, though, is when we do make improvements for Black women and marginalized people, everybody wins. At the beginning of the presentation today, you mentioned, Chelsea, you know, that it's also, we've got this issue around the fact that in the developed world, we are dead last. And that means everybody then is impacted, right? So we're talking about disparities, yes, and we must talk about disparities. And I'm very pleased and excited about the possibility of what Momnibus could stand for, because it is finally saying out loud, this particular problem needs to be addressed as a particular and distinct problem. Where I'm not so sure is when it gets out to the state level, if anyone's going to jump in and emulate and replicate those packages and move them. You know, we have state by state, especially southern states, a whole lot of extra to consider when it comes to policies that are going to work or be implemented really for the people that need them. And so that's where it's like, but I am very excited because I felt like this was the first time we've got something truly solid, outlining pretty well every aspect, and at least getting that on the table and starting the conversation, if nothing else.
So I think the key word is implementation, as Jenny was talking about. It's one thing to pass a package of bills, it's another thing to actually have them lead to changes in care. In California, we've had a law in the books now for about a year requiring providers to be trained in implicit bias. And it's sort of, we've developed the training programs, but it's pretty clear that 2 hours of training isn't going to be, is an important first step, but it's not going to change things in and of itself. It has to be matched with a broader program of anti-racism, of more general improvement in outcomes, and together with the clinical improvement projects we've been talking about. So the implementation really is a big piece. It's, you know, we're poised to expand care in Illinois and in California for up to a year. It takes a while to go through the Medicaid system, but no one knows exactly how to do it. No one knows whether, you know, the cardiologists are going to get on board and be willing to see patients with cardiac disease. So it's, you know, expanding Medicaid is a great first step again, but that's going to lead to a need for a greater number of additional steps before it's actually going to affect outcomes. So it's important, but I'm not sure that it's going to change the numbers in the next 2 or 3 or 4 or 5 years. Long term, I'm hoping that it will.
If you conceptualize this as a women's health problem, as opposed to just a maternal health problem, then actually expanding Medicaid in those states that haven't expanded would probably have a bigger impact than extending Medicaid coverage to the end of the year. It's one thing to say we're going to go from our 18% of the poverty level requirement in Texas or Alabama to 200%, and we'll extend that out to a year. I would much rather that all women get covered at 133% who are below 133% and actually get coverage whether they're pregnant or not. That will have a greater impact, but that at a state level is a more challenging, you know, we're a federal system and it's become a more divided federal system in recent years. So that challenge just keeps increasing.
Great, thank you. I'm so glad you guys returned to Medicaid because I know we had a question that you all essentially answered. So I appreciate that from the audience. I know we're short on time, so I wanted to end with one last question for you all. Are there other countries or models as well in the United States that are just doing it particularly well that the US should emulate? I mean, what comes to mind?
Healthcare systems around the world are all fundamentally different from each other too, in terms of how they're paid for, how they're organized. You know, the role of nurses versus midwives is very different. In England, for example, labor and delivery, you don't have labor nurses hardly. It's midwives or physicians is the major choice. But we've taken a very different approach. It's very hard to, and now in England, there's lots of evidence of disparity of outcomes among Black women, even in their National Health Service. The same in France. So we're all a bit imperfect, and I'm not certain we can look elsewhere to get the perfect answer. We just have to understand our system and see how to improve it, as others have been saying today.
I'd look less to the health. Oh, go ahead, Jen.
Yeah, I just wanted to quickly say, I don't know if there's any one specific country, but where women are treated respectfully, consistently, where they have access to quality and safety, they thrive. And I think that's the main real message. It's not so much the systems, it's how the systems, inside of the systems, how are the providers and the risk managers and the financial folk, how are they all on the same page around respect, dignity, safety?
And I'd look beyond the health systems in the other countries, so the social systems in those countries, because again, a big part of it is the fact that there's more support for people, again, whether they're pregnant or not, whether they're interacting with the health system or not. And so policies that might seem a bit extended from this, like paid leave, can have a much bigger impact than we would imagine on this. I'll just note one quick example. I'm part of a team that does these listening to mothers surveys. And we asked women who had paid leave from their employer, when did you start your paid leave? And the most common answer was on my due date. And that's because the paid leave was for such a short period of time that they wanted to save it all up for the postpartum period. In countries that have more generous systems, then women take the time off during their pregnancy, which is going to enhance the health of their pregnancy in order to do that. And so that's the kind of ripple effect that happens from social policies all the way through health. And so if we want to look to lessons from other countries, I would say, let's look at not only their health systems, but their social systems as well.
This has just been a fantastic conversation. I wanted to thank you all so much for taking the time. It's so appreciated. And yeah, thank you so much again. And thank you to our audience for all of your great questions. I really appreciate it. I hope everyone has a good day.
Thank you.
Thank you.
Thank you.